Welcome to Brain Wellness, the podcast. I'm your host, Mandi NP. What started as all things related to brain health and wellness has morphed into largely brain injury health and wellness, with occasional other neurological topics. My mission remains the same, to help you on the path to a healthier brain. So, without further ado, let's get into the show. Hello, everyone, and welcome back to another episode of Brain Wellness, the podcast. This week, I am back by myself again because I wanted to share some really cool information with you. Before we get into that, I just want to remind you that if you are here on a regular basis, you like the show, you like what you hear, please share it with others, repost it when I post the announcements on the show so more people can hear this because it's just a lot of really good information. Would I love to monetize and make money on the show? Absolutely. But in reality, I just want more people to listen because it's really, really good information that I share on a regular basis. And I just want more people to hear it. So listen, if you listen, like it, comment, subscribe wherever you listen, share it with somebody else who's not listened to the show before, whether it's your favorite episode or just the show in general. I do appreciate all of you being here and coming back week after week for more information because we've got some really good guests that have been on the show. And I'd like to think they're really good shows that are solo, and I just share the information that I have learned with you guys about all the things in the land of concussion and traumatic brain injury. So this week will be no different from all of that. This past week I got to spend in Los Angeles, California, a little farther away from cold Minnesota, but the temperature actually wasn't that much different when I got there. But I was out there for, initially what I was thinking was a national conference, and it ended up being an international conference, truly. So I was out there for the Society of Brain Mapping and Therapeutics, also known as the World Brain Mapping Society. So I not only made connections across the country here in the United States, but also with people from Canada, from Israel, from Australia, and others that I can't remember off the top of my head right at the moment, but I took a lot of really good notes from this past week and saw a lot of really good presentations, met a lot of really interesting people who I'm now good friends with some of them. So it's really kind of interesting and fun to see all of that. So I did want to share a little bit of information with you guys too, because I gave a presentation at the conference as well. So without further ado, let's get into all of that information. I wanted to share with you a little bit about my presentation, which I called, Is it whiplash or concussion? So we've had some of these conversations on this show previously, but this is one that I've seen quite often because patients just don't think about it. So my objectives for this one, I shared a little bit about my background experience, the symptoms that I experienced. If you've been listening to this show, you kind of know some of those. And then I defined what whiplash is and what concussion is and identified the overlap of those symptoms. And then went through some of those treatment options that help this population, incorporating both traditional and non-traditional therapies. So again, shared some of my backstory. If you're new to the show, I'll tell you that I've been working in neurosciences to some degree since the year 2000. So we're 2026 now, 26 years that I've been working in neurosciences. I've been a nurse since 2002, nurse practitioner since 2012. Again, essentially all in neurosciences. And I thought I was really giving good care to my concussion patients, my TBI patients that I cared for in the hospital until April of 2023. So we are just now at that 3-year mark when I was in my motor vehicle accident and life stopped in its tracks. I didn't even recognize my own symptoms, which was a major problem. And I had been a neuro nurse practitioner as long as I have, so I thought I should know the things, but I didn't know the things. The only thing that I really knew is that I had a really, really, really bad headache. And over the next weeks to months, we identified that I had issues with balance, vision, reading and auditory comprehension, memory issues, impaired executive function. I couldn't make a decision to save my life at that moment. Autonomic nervous system dysfunction, exercise intolerance, sensory sensitivities, irritability, mood changes, and it all led to some depressive symptoms because who wouldn't be depressed for months and months and months and now then years of not being able to get back to work? It was a pretty sad situation at that point. So first off, what is a concussion or traumatic brain injury? Again, we've talked about this many, many times on the show, but the information that I shared in my presentation again looks at the 3 main categories, the historical definition of traumatic brain injury: the mild TBI, moderate TBI, and severe TBI. Mild TBI, when we look through these mild, moderate, and severe TBI, we really separate out by loss of consciousness, changes on head imaging, and that Glasgow Coma Scale looking at eye, verbal, and motor responses. So Glasgow Coma Scale, for those of you not familiar with it, it's a score of, what's the lowest you can get? 3, all the way to 15. So 15 is normal, and the lower the score, the worse the outcome typically. Mild traumatic brain injury is loss of consciousness is either minimal or not present whatsoever. Most patients don't have a loss of consciousness with that. Changes on head imaging does not exist with a mild TBI, and Glasgow Coma Scale is in the normal range between 13 and 15. A moderate TBI then has loss of consciousness from just a few seconds up to 24 hours. It's possible to have some minimal changes on the head imaging, such as a bleed or a fracture, and the Glasgow Coma Scale is a little bit decreased, somewhere between 9 and 12. The severe TBI is someone that has a loss of consciousness typically greater than 24 hours. They definitely have changes on their head imaging, either a bleed or a fracture, and in some cases a very small stroke can be seen as well. And their GCS is definitely decreased at 9 or below. The mild TBI category accounts for up to 80%. They are estimating up to 80% of all TBIs are in that mild category. Mild TBI, as we've talked about many times on the show, is a concussion. A concussion is a mild TBI. So when we talk about whether or not somebody has lost consciousness with a concussion, most people that have a concussion by that definition don't have loss of consciousness, and if they do, it's very minimal. So when we have that confusion about whether or not somebody had a concussion because whether or not they lost consciousness, that doesn't really fit into the equation very well. What are some of the symptoms? Again, things we've talked about in the show many, many times. On my slide, it's just covered with words. So headache, vision difficulties, word finding, slurred speech, short-term memory troubles, forgetfulness, dizziness, balance, coordination, activity intolerance, sleep disturbance, seizures, irritability, mood swings, fatigue, weakness, numbness, the list goes on and on and on. Reading comprehension, hearing comprehension, problem-solving issues, concentration issues, slowed thinking, confusion, word substitutions, depression, anxiety, sensitivity to light, sound, smells, loss of taste or smell, personality changes, hearing difficulties, tinnitus, changes in appetite, nausea, vomiting, autonomic nervous system dysfunction, neck pain. And I could keep going on and on and on because the slide that I have is very busy, but it is not all-inclusive of all the symptoms of TBI. And no two patients with TBI typically look the same. Once you've seen one concussion, you've seen one concussion. I heard that term last year, and it still fits because, yes, there are similarities across the board, but there's a lot of things that just are individual to each person as well. So what is a whiplash is the next thing I talked about. A whiplash, as defined by Mayo Clinic, is a forceful, rapid back and forth movement of the neck. It typically is caused by rear-end motor vehicle accidents, physical abuse, falls, also known as neck sprains or strains, and I like to kind of call it a little bit like an adult shaken baby syndrome. So you shake that head really hard, and you get that rapid back and forth movement of the neck. You get the whiplash symptoms, but guess what? That's not all you get. So whiplash symptoms, in the research, when you look up symptoms of whiplash, it tends to be neck pain and stiffness, headache, fatigue, dizziness, numbness and tingling in the arms potentially, and blurred vision, tinnitus, irritability, memory problems, mood changes, difficulty concentrating, sleep disturbance. Do any of these things sound familiar? They should, because as we think about that, literally all of the symptoms of all the symptoms of whiplash are the same as the symptoms of TBI. So every single one of them, plus probably more, because I think when people document about whiplash, they're not asking cognitive symptoms. They're looking at some of these other things related to neck, but they're not really thinking up higher than that very often. So bottom line in my presentation, I was trying to get people to understand, and I'm trying to help you guys understand as listeners, that whiplash is a concussion. Whiplash leads to the same contra coup injury to the brain that happens with that mild TBI, that whiplash, that concussion category. So the contra coup, again, we've talked about this on the show, but the coup is that primary impact when the head, so if you're getting hit from behind, for example, your car's hit from behind, your head rapidly moves forward. The coup injury is where your brain strikes the front of your skull. And then you rapidly move backward again, your brain strikes the back of your skull. that injury causes injury to the brain. It's not just the neck that we need to deal with on this. And the thing that I kind of highlighted on this slide is that this was my experience. So I was in a car accident back in 2023. I didn't hit my head in the car. It was all whiplash injury that led to my concussion that kept me out of work for almost 2 years. So it wasn't just a whiplash. It was much more significant than that, but we tend to not really put those two and two together. Now, whiplash and concussion, when we look at all the research, they tend to be studied independently. They're often not talked about together. Primary care does a pretty decent job of identifying whiplash, and they often may refer a patient to a spine specialist for the cervical spine, those neck injuries, and getting some treatment for those neck injuries. However, 60 to 70% of those cases get misdiagnosed, meaning they're just diagnosed as whiplash and they don't get that concurrent diagnosis of concussion. So they're missing that diagnosis and missing the treatment. Some of the treatment then that we can offer, whether it's concussion or whiplash diagnosis, really the treatment is going to be the same at this point. So PT, OT, speech therapy, those are all things that we've traditionally done. Those are our traditional treatments. And traditionally for the whiplash side of things, patients tend to get referred to a spine specialist to get evaluation of that cervical spine, see if we need to do any interventions specifically for that spine injury. Non-traditional treatments, the world is your oyster at this point, right? So this was the meat and potatoes of this conference that I just went to. It was neurotechnology. And a lot of the things that were on this slide were on the topics for this neurotechnology conference, which was really cool. So photobiomodulation, also known as red light therapy. We've talked about this on the show several times, all the way back to like in the early 50s episodes when we started talking about all my treatments after my injury. So red light therapy in the form of bed or in the form of a transcranial laser or cervical laser treatments as well. That's still photobiomodulation, just focused, targeted at the area that's injured. The purpose of the photobiomodulation, transcranial, or the cervical laser treatments is to decrease inflammation, increase blood flow so that we can heal. The next couple on the list, EWOT and HBOT. EWOT is exercise with oxygen therapy. HWOT is hyperbaric oxygen therapy. Again, very similar processes. Hyperbaric, you're sitting in a chamber for 60 to 90 minutes, breathing 100% oxygen. And then the exercise with oxygen therapy, you're typically riding a bike, wearing a mask, breathing 92% oxygen. And it takes about 15 minutes because you're actively pushing the oxygen into your body. When we had the episode with Hypercharge, again, back in the 50s, when we talked about the photobiomodulation for the first time, we also talked about EWOT on there. HBOT I've had on more recently with a guest as well. A former USA team bobsledder that talked about his experience using hyperbaric oxygen to recover. Neurofeedback and PRTMS are the next two on there. They are both EEG-based treatments. So neurofeedback, I talked about with a couple of different providers on here. So neurofeedback is really amazing for retraining the electrical system in the brain. You start either one of these, PRTMS or neurofeedback, starts with getting a brain map first. So you map it out with a quantitative EEG. You do the treatments using the EEG-based treatments, or the PRTMS is personalized, repetitive, transcranial magnetic stimulation. I had Dr. Kevin Murphy on here a while back, and we talked about PRTMS through his organization, Peak Logic. And then both of them, neurofeedback and PRTMS, we end up doing more brain maps at the end to show the difference. What did we do in that treatment? How did we get it better? And then the neurostimulator devices, such as the Dolphin, the Apollo, the Pulsetto, all of these work on stimulation of peripheral nerves, such as the vagus nerve is one of them. I'm wearing my Apollo device. That's my latest one. I started out using the Dolphin quite a while ago. That helped. There are many more things that I could have done with it, but I didn't get all of the training that I potentially could have with that one. The Apollo device I've been using most recently because I can wear it all the time. It doesn't make any noises, so it doesn't disrupt anything. That one has been saving my life this past week, to be honest. And the Pulsetto is one that you wear around your neck, and it sits on that vagus nerve. I have a couple of patients who have gotten that one, and it definitely does calm the nervous system on those and gives them a little bit more rest on those. And then the last thing on my slide is neurological chiropractor. So again, Dr. Brandon Allen was on here with me, neurological chiropractor, real close to here in Minneapolis, that helped treat me. I refer to him a lot because he does amazing things with patients working on autonomic nervous system. He uses a lot of technologies like this. And I met other neurological chiropractors out at this conference. again, they were thrilled to see that I had them on the slide because they utilize so many of these technologies all in one place, which is really cool because it's hard to find many of these all together with a practitioner who understands how they work. My final thoughts on my presentation was that I want to get people out of the thought of thinking that whiplash and concussion are two distinct diagnoses. We need to think about both. So when someone is coming in and they've been rear-ended in a car accident, they fell, they didn't hit their head, but they've got symptoms of whiplash, we also need to assess them for symptoms of concussion and treat both of those things, because does every whiplash lead to a concussion? No, but a lot of them do. So we really need to address both of those things. And regardless of how we get that diagnosis, the faster the treatment, the faster and the better the recovery is. Whether we're using traditional or non-traditional treatments, it still gets people better faster. And if they're trying one thing and it's not working, we need to start identifying these possible non-traditional treatments, which I hope at some point will just be traditional. That's just going to be the protocol for treatment. And it can still be helpful later on. So even if we miss that diagnosis right away, which is still happening for patients, if we get the diagnosis later, we can still treat and they can still see improvements. And I've found in my own recovery and in the recovery of many of my patients that anytime we get to a plateau, it's just a pivot moment. We need to try something else. So that was my big thing on this presentation. And I kind of joked a little bit as I was getting this one ready, because I talk about that misdiagnosis of missing the diagnosis of concussion with those whiplash patients. This week, right before this episode comes out, we've got the Minnesota Brain Injury Alliance conference, and I'm presenting at that one about missed diagnosis and misdiagnosis. So that's my whole talk, is the misdiagnosis thing. So I'm really excited for that. By the time you guys hear this, that conference will be over, so you won't be able to attend anymore, but it's really good information. And I'll probably come back here and share some of that information too, because I just can't help sharing. What else did I learn at the conference? It was an amazing conference. So many great speakers. I made a lot of new, really good friends. And a lot of my time was spent in the military medicine section. So a lot of the military medicine talks had to do with traumatic brain injury. Probably not surprising many people, but a lot of them had to do with TBI, PTSD. So I found those very useful for the VA population that I take care of, as well as the civilian patients that I take care of, because a lot of those treatments can be beneficial for both populations, military and civilian. So you guys have heard me talk about EMDR on the show. I have not had a specific guest to talk about that in particular, but we've talked about ART and brain spotting, other things like that for that trauma therapy. The military is utilizing this new tool called EMDR, which is essentially three-dimensional. They're using VR-based treatment to do that trauma-based therapy, which was really cool to see the videos and see all of this. I did have to laugh a little bit. There were a lot of conversations about the use of AI in medicine. And I think that's going to be coming up quite a bit. And as much as I hate to jump on that AI bandwagon, it was really neat to see how we can utilize AI for things like this type of therapy, where you're immersed in that kind of desensitization trauma therapy so that you can move past the trauma and learn to heal. So it was really neat seeing that use of it, because it's not something I would have thought of previously. There was a lot of really, really good tools that are being used in research right now that I hope we'll see coming out into practice at some point. There was a lot of talk about concussions, about subconcussive injuries, about does the distance between the weapons make a difference in how much concussion somebody experiences. Does positioning on the boats for such as like Coast Guard and things, does it make a difference where they're positioned on the boat when a blast occurs? And it was really fascinating hearing all of these things. And I'm hoping to get one of my new friends from the university, the Uniform Services University out in Bethesda to come out here and talk on the show as well. Probably not come out here. It's too cold here in Minnesota, but maybe get them on the show and talk about some of the research they're doing, because it was really cool to hear all of the things that they're looking at and trying to identify ways to help our service members, and ultimately that we can take back to help civilians as well, because there's a lot of really, really neat research that's going on that more people need to know about. So it was really kind of cool. Other things that I saw right next door to the military medicine was the optometry group. So I've had Dr. Wallerick on here. very great resource here in the Twin Cities for neurooptometry. There was a lot of talk from both the military medicine side of some of their optometric exams that they're starting to use, as well as within the optometry community, as well as from functional chiropractors coming in and talking about that neurological chiropractor experience with evaluations using V&G, looking at eye movements and identifying how we can functionally help patients see better after brain injury, for example. What else do I have in my notes? Light therapy is part of the optical training. There was so many good things on here. I did also sit in on one of the Neurotech sessions, and they're doing a lot of different, these had no relationship to TBI, but it was interesting to see how all of the different neurotechnologies are being used in different areas of medicine, from bladder retraining to suckling with babies, teaching them how to nurse appropriately if they have issues with nursing. So many different areas of life where we see these neurotechnologies popping up. So if you are a provider in the traditional medical space right now, you really need to start looking at some of these neurotechnologies and technologies in general in medicine, because all of these technologies are going to be really helpful in helping our patients get better. I mentioned that to another provider I know, and they said, you know what, I don't want to learn anything more. And that kind of breaks my heart a little bit, because I love learning and I am such a nerd with all this. And I told so many people that I met at this conference that I am such a nerd, and I'm proudly a nerd on this because I love learning about all of these new things that are coming out. And I love that I can come back and I can share this with my listeners, with other colleagues that I work with, so that other people can learn about the things that we talk about. So I learned about TMS. There's different companies working with TMS, different programs, different types of TMS being done. We got into the whole women's health thing with women's health in the military and talking about their blast exposure and toxin exposure in the military and how that may affect their reproductive years, and things that I don't know that I ever really would have thought of before, but so much more than just TBI. And it was really cool to hear all these things and see all these people from different walks of life and at our table one night. So it was not just the international experience at the conference, but we also ate some really good German food, Japanese food, Mexican food. And I still laugh that it was at the German restaurant where we had people from Israel, from Toronto, from the United States, all over, all together eating German food and talking about all of our neurotechnologies as we were sitting at the tables at this restaurant. So it's really cool to get all of these people together and all these different practices. And we had oncology at the table. We had women's health. We had researchers. We had myself in concussion. And having us all have things that we could talk about together with our different therapies and treatments and how we approach our patient care and how we approach research so that it can help the providers, the practitioners of the world. It was really cool to be a part of this, and it was a really exciting experience. And I hope that I can go back again next year and bring some more of my colleagues and the people that I work with in this TBI space, because I think there's so much that we can learn from each other that, again, if you're a provider listening at any level, I hope that this has maybe gotten you a little bit inspired and excited to look at some of the different technologies that you can use in your practice, or the things that you might be able to refer patients to, or just be knowledgeable about some of these things that are available for our patients so that we can help them get better in multiple ways. This is not the type of medicine that we learned about 20 years ago. This is 2026 medicine, when we have things like AI and technologies that help calm our nervous system on a daily basis as we're sitting at our computers trying to record a podcast frantically to get it done. And all of these technologies that help us to be better practitioners. Am I a little scared that at some point AI might try to take over my job? Sure, but in the meantime, I can use these technologies to help my patients, and I'm really excited about that part. Again, I hope I got you a little excited. I hope you learned something new in this episode, and I hope that you'll come back next week to hear something more. And in the meantime, if you like this, share it wide, get lots more people to listen, tell somebody about the show so that we can get more people listening and learning, because I love this show and I love my listeners. So thank you guys so much for being here. Thanks for tuning in to this episode of Brain Wellness, the podcast. If you enjoyed this episode, I encourage you to subscribe, leave a comment, and share it so that others can benefit. Please also consider supporting the show by buying me a coffee. The link is in the show notes. You can also go to www.brainwellnesssolutions.com to catch the latest info and get links on all of the social medias there. See you next time.